Yep.
Oh boy. You want to
You
have
guys
everyone?
actually in here, this is the live webcast.
You want to have everybody move up to the front so
That's
that
what I
the
was thinking.
camera looks a
Yes.
little fuller?
Yes.
You
Yeah.
know?
Yeah, if you guys want to, how about everybody moves up to the front? Come on down. Yeah, yeah.
I think this technology plan is, people will be beginning and then they sort of recognize the network and all that other sort of stuff. Yep.
All righty. Where's my pen? Where are my bios?
So we know we lost Michelle Rook. She went down to Florida. Yeah.
Yep. Yes.
Yeah, she's got two kids.
Right.
Yeah.
Yeah, that one's a walk around. Okay. Okay.
Congrats. Not that you haven't gotten close. He had no other job. Yeah. Yeah.
Okay, so I was carrying so many pieces of paper around that I got in here without my bio sketches. So we've already heard who David is. Everybody knows him. And Jeff, you had an introduction earlier. So I'm just going to hand the microphone over and have Phil and Kristen just give you a brief intro. Is it on?
I'm Phil Rosenthal. I'm a pediatric hepatologist at UC San Francisco. I've been involved with the Alagille Syndrome Alliance, I don't know, 15, 20 years, something like that, a long time. I'm part of the Children's Network, which you may have heard about, and I'm happy to be here.
Phil is a giant in the field. He's been a role model for many. He's everywhere in anything. And a liver trial can't exist without Phil being in it. I just want to say. This is Kristen.
I'm not that important. And I'm a mom to Emery. I think I've met most of you a little bit already, but my daughter is only 3 years old, so we're relatively newly diagnosed as well. So our first symposium was just a couple years ago. So that's why I'm here, because I'm still kind of in the new diagnosed world, but really excited to connect with you guys and kind of be an advocate for the new families.
And what I was thinking, Patty, since we have a pretty small audience, is why don't we pass the microphone around and have you guys tell us a little bit about who you are and maybe the age of your child and when you were diagnosed. Just kind of give us some background information so that we can target the discussion a little bit more.
Okay, and as I'm walking, I'm going to say I'm Patty Everett. I'm a board member, and I have a 20-year-old son who has Alagille Syndrome and was transplanted 13 years ago. Not to put you on the spot.
Yeah. Hi, I'm Leonard Chow. I am the grandfather of a Alagille syndrome child. He's 13 now, and a few years ago at 9 had a liver transplant, and the difference is really tremendous. In the year prior to his transplant, I guess at 9, when it's usually peak growth years, I think he gained 1 pound that whole year. I think the 9 months or a year after the transplant, I think he gained 30 pounds and grew 2.5 inches. So it's a great success story.
We are Kristen and Jay Christensen, and we have 3 boys, 10, almost 8, and then our 2-year-old Tanner has Alagille syndrome, and he was diagnosed at 6 weeks of age.
We're Candace and Dan Capellas, and we also have 3 boys, 10, almost 3, and our youngest, Ashton, who has Alagille's, is 15 months. And he was diagnosed at 7 weeks.
We're Tim and Bethany Eibach and Papa Gary. We have 3 kids as well. Was it 9, 6, and 2, and Ben is our 2-year-old, and he was diagnosed about 6 weeks in. And just recently went on the liver transplant list. So.
My name is Hamid Jafar Najad. I work at Baylor College of Medicine in Houston, Texas, and we've recently established a mouse model that recapitulates some of the aspects of Alagille syndrome, and we hope to be using that in better understanding the disease and potentially testing some therapeutic approaches.
Good afternoon. My name is Ton Bunt. I have 2 hats today. I'm here as the Senior Medical Advisor of Alagille Pharmaceuticals. We're developing an IBAT or ASBT inhibitor for children with liver disease. I'm also the father of a now 8-year-old girl who had biliary atresia, a Kasai, a transplant, cancer, and is now healthy. So we've gone through quite a bit.
All right, well, we have a 2-year-old. He was diagnosed with biliary atresia as well. And they went in to do the Kasai and found that it wasn't biliary atresia. And they actually did they did the cleangelo, or what is it? Yeah, intraoperative cleangiogram. And they tested for Alagille, and he said it was negative at the time. And then the biopsy came back negative. And then geneticist. Yeah, the vertebrae, one of the vertebrae behind the rib cage was slightly the butterfly, and I guess the surgeon didn't see that. I don't know. I'm not a good talker. And, that's it.
I have a kind of unique situation. So I teach early start, so I do home visits for kiddos, and I have a new referral. It's an 11-month-old baby that just got newly diagnosed with Alagille syndrome. So I'm just coming to learn more about it because I'll have him until he's 3, so almost 3 years. So yeah. So I think I'm the only one here that's not a parent, but I definitely have learned a lot already from just hearing your guys' perspectives. And so I'm looking forward to kind of communicating that to the family, because I think it can be overwhelming a lot of times when you get a diagnosis from a doctor, and then it's like you're in the shock, right? Ends up kind of breaking it down later, kind of like you're doing today. Yeah.
Thank you.
Thank you all. So you're in the right place to learn some more, even more than you've learned so far. And I guess I'm going to kind of flip down through some of this because we've already seen it. And okay. So how many of you have heard the little story, Welcome to Holland? Raise your hand if you have. Okay, so one. So I'm going to share it because this was one of the first things that I ran across when my daughter was diagnosed 25 years ago. And it kind of put things in perspective for me. And I was going to, I actually have some tulips that are part of the props for this, but again, I didn't bring them. They're in our war room, what we call our war room for the board. But I can pass them out later, I guess, maybe at dinner tonight. Anyway, so about 30 years ago, Emily Pearl Kingsley, she wrote about her experience when her child was born with Down syndrome. And I came across her essay shortly after she wrote it, and my daughter was diagnosed in 1990, and it helped me work through some of the feelings that I was experiencing, and I just thought I would share it here. And so it kind of goes like this. So I'm often asked to describe the experience of raising a child with a disability, to try to help people who have not shared that unique experience to understand it and to imagine how it would feel. It's like this. When you're going to have a baby, it's like planning a fabulous vacation trip. You're going to go to Italy. You buy a bunch of guidebooks and you make your wonderful plans, and you may learn some handy phrases in Italian, and it's all really exciting stuff. And after months of eager anticipation, you pack your bags and off you go. And several hours later, the plane lands, and the stewardess says, "Welcome to Holland." And you go, what does that mean? And you go, Holland? What do you mean Holland? I signed up for Italy. I'm supposed to be in Italy. All my life I've dreamed about going to Italy. But there's been a change in the flight plan. You've landed in Holland, and there you stay. And you might buy new guidebooks. You have to learn a whole new language, and you'll meet a whole bunch of new people that you've never met before. Holland is slower paced than Italy, less flashy, but you begin to notice that Holland has windmills and tulips. It even has Rembrandts. And everyone you know is busy coming and going from Italy, and for the rest of your life you'll say, yes, that's where I was supposed to go. That's what I had planned. And the disappointment of that, the pain of that will never go away, because the loss of that dream is really significant for you. But if you spend your life mourning the fact that you didn't get to Italy, you may never be free to enjoy the very special and very lovely things about Holland. That's what the tulips are about, which I was going to bring to the session. And it's to remind us that wherever you find yourself, although it isn't what you expected, it's your new normal. And it can be really beautiful, and it can give you a whole new perspective on things. So with that, so the new normal is, you've seen this slide before, full of lots of words that you've never heard before. And lots of things, trips to the doctor's offices and tests and all those kind of things. And it's also when you have a little one, Alagille syndrome, it seems to revolve around things like eating and sleeping and bowel movements, which we talked about a lot this morning, and a whole lot of specialists and a ton of information that you really don't know much about. And you know, it seems like there's a long list of tests that they have to do or that they're used to diagnose. And, you know, you spend a lot of time in doctor's offices. And one of the things that we did in the ALGS Care tool is that at the back of that, you'll find some resources to help you. So there are things like lists of specialists and what they do, and what challenges they might look at. There's a really helpful checklist that David provided that they use when they have a family coming to them for a second opinion that kind of walks you through all the different things to think about with Alagille syndrome, and it's very helpful when you go to your doctor to kind of think about and talk about all of those things. So eating and digestion, we talked about that some this morning. When a person with ALGS, when you have an infant or a toddler, there are some kind of special considerations that you have to keep in mind. And there's also a lot of concern about growth failure and failure to thrive. And I wanted to ask David, so years ago, you put together the growth chart for Alagille syndrome. And I'm wondering if you can share with us, you're doing an update of that? Okay, so if you could tell us a little bit about that. Microphone's there somewhere.
To say that I'm doing it is overly generous. But Henry Lynn, who'll be here a little bit later on today, is doing it. We collected a lot of growth data. So the first one we did was based on a relatively small number of patients, and you have to split it into male and female. And what we really just wanted was something that gave us an approximate idea of what the Alagille regular growth looked like, so that we could say, you look terrible on a regular growth curve, but you look great on the Alagille growth curve. But also remembering that that was done at a time when we were not nearly as aggressive or effective at replacing nutrition and doing other things. If you go all the way back to Alagille's papers, they had a number of complications that we essentially never see anymore because we treat vitamin deficiencies and nutritional deficiencies and other things much more effectively, and they did absolutely nothing because they couldn't. So Henry actually Cindy was very helpful with getting growth data from the Alliance. We got it from other centers and so on. And so the one that he makes will be both modern and much more accurate, and he's doing it with Dr. Babette Zemmel, who is, she's a growth expert, PhD, in our nutrition section. And we will, at some point in time, rip the old one up and take it off of the website, because the new one will be higher. I think we also, it's a little bit complicated to know, should your growth curve, so the studies in the 70s and 80s on Alagille syndrome all required that you had relatively bad liver disease plus at least 3 other things. And so those were the sickest of the sick kids. And now we recognize that there's a broad spectrum, and it's somewhere between 1/4 and 1/2 of the people who carry the mutation have something that we would recognize as Alagille syndrome. So it's a little hard to know, should you be comparing people to the sickest of the sick or to everyone, but is it fair to compare a sick person to someone who is relatively asymptomatic? So there are some vagaries of this, but I think it helps people to look on that curve. We don't set unrealistic expectations. I think Laura said that last night. You don't expect, even with infinite nutrition, if you're a 6'4" father and a 5'11" mother, but your child has Alagille syndrome, you really cannot expect that they're going to be a 6-foot child. It just doesn't. There are a number of genetic diseases where the expectations are different, and you want to aim for the best of those expectations, not to push for something unrealistic. So it's coming out, though, because Henry took it over, and Henry is a completer, and I am a piler on the corner of my desk person.
And just like, there are rogue waves, I'm going to have a few rogue questions here. So I was wondering, Jeff, can you talk just a little bit about how much do cardio and vascular problems affect growth and growth, contribute to growth failure?
Yeah, so it certainly depends, excuse me, on what the vascular abnormalities are, right? So if it's something like a simple coarctation, that can be repaired, for example, in infancy.
Mm-hmm.
In general, it doesn't affect growth very much. If you have something like Tetralogy Fallot that has a lot of other components to it, that could certainly affect growth. Again, oftentimes in the simple versions, repair will get rid of the growth issues. When you get into some of the more complicated lesions, the ones that involve the pulmonary arteries, especially if you end up in the world of heart failure,
Mm-hmm.
then you can certainly have growth failure from cardiac issues on top of the baseline growth issues associated with Alagille. So it comes down mostly to whether the lesions are repairable. When they're repairable, in general, you don't have as many issues with growth. And then the severity of the residual problems that are still left.
Mm-hmm. Okay, so, and also as we go through this, if you do have questions, go ahead and just put your hand up and Patty will come over and bring you the mic so we can add those to the discussion. So another issue is eating food, getting the calories, getting the nutrition that you need. And we talked a little bit this morning about tube feeding, and there are a couple different kinds of tubes. So there's an NG tube that goes through the nose down into the stomach. And then there's also a G tube, or sometimes it's isn't that a peg also? So it's like, it's a button. So it's actually a button that's put on, goes directly into their stomach that you can hook up, and then the formula will be fed directly into their stomach. And a lot of times you do that at night for them. You can also put their medications through there. And I guess one of the questions I had was, how do you decide? Where do you make that decision about tube feeding versus not? With for instance, with my daughter, she never was tube fed. She grew very, very, very slowly, and I heard about it every time I took her to the pediatrician that, hey, she's like below the 5th percentile. Do you think we should do something about that? But she continued to grow. She was, she hugged the curve. And so, question is, when do you know when your child should be having tube feeding?
Nothing in medicine is black and white. That's the first thing I'm going to say. So I think one of the critical points is to follow a child. And if we're concerned about growth, because one of the major things a child needs to do is to grow, then it's important to get a calorie count and see actually how many calories the child is actually consuming a day. And I'm sure you're all very well aware that from day to day, the intake of any child is very variable. Some days kids may eat very well, and they may even eat all their vegetables. And other days, they may not do so. So you want to get an average of what is an accurate reflection of what's being taken in. And then dependent on their age, there are some formulas that we can use of how many calories per kilogram per day that child is taking. And if you're not reaching that goal, then the question becomes, how can you do that? Again, sometimes we'll just supplement a formula. Sometimes we'll suggest that they take an extra, glass of Boost or Pediasure or whatever to get those calories in. Some kids, unfortunately, will vomit. And you know that if you're vomiting, you're not actually getting those calories in. And if that's the case, then a decision could be made, how could you get the same volume and the same amount of calories in the simplest way? And that's often when tube feedings become in the equation, because what you can do there is you could even feed someone while they're asleep. So you could slowly, continuously drip in feeds. And that's, again, it's all variable dependent upon the individual patient. But that's one of the reasons why someone would wind up with a tube. And then, obviously a nasogastric tube is not very pleasant to go out into world, people are going to look at you probably a bit strange. And there's concerns for sinusitis or infections as a result of the tube blocking your sinuses. So if you're going to be long-term on tube feeds, then usually a decision is made to do a gastrostomy.
And Kristen, has Emery had any tube feeding? No. Okay.
Emery never had any tube feeding. She was actually wouldn't take anything. I had a breastfeeder for 2 years and just supplement her, and they wanted to mess with her. But for her, as long as they saw her moving at her own curve, they were happy. And that's what we've done. We just keep watching, making sure she's on her own little curve.
And let's see, are any of you, do you have, I'm trying to remember the ages, but are any of yours still on bottle feeding, so formulas, that kind of thing? A question I have is about breastfeeding versus formula feeding. I know with Elena, when she was, like very early on, they want, and of course this was 25 years ago, so things have changed a lot since then, but the recommendation with her was, no, go to formula feeding, forget the breastfeeding. And so I'm curious, what are the pros and cons of continuing breastfeeding versus going to a formula?
Can I just give my opinion on that?
Yeah, go ahead.
They really pressed me to do the formula. She didn't really want the bottle though, and she was growing okay, and I wanted to stick with the breastfeeding, and she ended up being really successful and grew really well. Her jaundice went away really quickly. So for her, I really do think it's not gonna be black and white. I think breast milk is a factor, and the child and how they're absorbing that. For Emery, it happened to work out that was what she needed. And we still would supplement, but the nutritionist was thinking I was crazy. But I also think that's where parent gut comes in a little bit too. You got to factor that in, but I don't know. That's what we chose to do.
So the advantage of breast milk is that there are immunologic factors in breast milk that you'll never get in a formula. However, if you're cholestatic, you can't absorb fat and fat-soluble vitamins very well. And therefore, breast milk may not be the most complete formula for somebody who's got liver disease and is cholestatic. And therefore, there are certain very specific formulas that have simpler fats in them because you need bile acids to help you absorb fats. And if you're cholestatic, you're not going to have good numbers of bile acids necessarily in your intestines to absorb those fats. So some of the specialized formulas have a certain length of fat called medium chain triglycerides, which are easier to absorb and don't require you to use those bile acids to form these little particles called micelles to get the fat up into the body. In general, again, I think it's an individualized approach because I think there are advantages and disadvantages to both ways of doing things, and there's no one right way. Again, it's not a matter of what's in the formula as much as it's a matter of how many calories are actually absorbed. And if you're malabsorbing everything, then you're really not, just because it goes in this end, if it comes out the other end, you're not accomplishing anything. And that's why calorie counts and the growth curve itself become the critical factors in determining if you need to make a change or not.
And a follow-on question. So if they're not tube fed and they're a little bit older, 2 to 3, what are the better, there's Pediasure, there's Boost, there's those kind of things. Are there pros and cons of those? Is there one that's more recommended?
Yeah. So again, it's a matter of how cholestatic you are, because if you have significant liver disease, those formulas, if they're similar to the general population formulas, they're not necessarily specific for patients with liver disease. And there are even adult, very specific liver disease formulas. They're not very palatable, and I suspect you're not going to get most patients to take them. So again, that's another reason for using tubes, because then you don't have to taste the stuff. Because if you've ever tasted progestamil, you would know what I'm talking about. It's not very pleasant. The good news is that most babies actually, their taste buds haven't developed yet. So though you may not like it, if they're hungry, they probably will take the progestamil. But as they get bigger, I can guarantee you that if they know there's an option besides progestamil, they will probably choose that.
Right. Fat-soluble vitamins. We heard about these this morning. We talked some about, the different vitamins and what they do, and the prepared vitamins versus separate vitamins, and injections versus oral vitamins. Is there anything that additional that you might want to say about those?
Yeah. So the first thing I will say is that unfortunately, even if you're taking fat-soluble vitamins, and that's ADEK, A, D, E, and K, the formulations that are currently made by vitamin companies are not specific for cholestatic liver disease. The ratios of those medications are not what you would give someone with liver disease. They're made for someone with fat malabsorption, for example. So say patient has cystic fibrosis. That's where those vitamins are coming from. So the combo is not the cholestatic vitamin preparation that I would like to be able to take off the shelf and give to somebody that has liver disease. We've attempted within our childhood liver disease research network, actually, to try to convince vitamin companies to make a formulation that would be more appropriate for kids with liver disease. Don't hold your breath, because it hasn't happened yet, and I don't anticipate that it's going to happen real soon. Therefore, you have to wind up monitoring a child's vitamin levels and supplementing them if they need it. And in Alagille, as I'm sure you heard over and over, there's issues with bones, and vitamin D is a key player here. Vitamin E, by the way, is the hardest of the fat-soluble vitamins to absorb. And I'll give you a small anecdote, because I suspect David was involved with this also, but way early in my career, probably in the middle of David's career. No, I'm only kidding. I'm only kidding. But he probably remembers having to make up preparations of vitamin E. And I remember my wife very distinctly giving me a hard time, because we used to get these blocks of vitamin E from Kodak. That we used to make up, and I would not make it up in the lab because I didn't think it was clean enough to give to my patients, actually. And we used to have to melt down in boiling water this block of vitamin E, basically, and put it into a bottle that was clean and would then be liquefied. And you couldn't put it in the refrigerator necessarily, because it would then solidify right in the bottle. And I very distinctly remember doing this to get vitamin E into my patients with bad cholestasis. Predominantly, they were Alagille patients. So we've gone a long way. At least now you can get, vitamin preparation that has vitamin E in it.
All right. So moving on a little bit here. Going down and coming up. David mentioned a little bit about reflux and spit up. And I know from my experience, my daughter it was like a waterfall. She would drink, a little 2 ounces or something, and half of it would come back out. And so is that related to Alagille syndrome? And is there something that parents can do to keep it down?
It's a problem when it happens. it's not tremendously more common in Alagille syndrome than it is in other children. And, we have only rarely seen sort of the twisted or the congenitally abnormal intestine that would be like a big problem cause for reflux. And there are a lot of babies that are happy spitty babies where it comes up like a waterfall, and then she was willing to take it back down again 20 minutes later, But I think the calories are precious in Alagille syndrome. And so you feel under significantly more pressure. And, we use the acid blockers, and people think it cuts reflux. It doesn't really. It kind of cuts the acid in the reflux. And we use prokinetics, things that push things forward. But usually by the time that really matters, you're also on a lot of other meds. And interestingly, tube feeding, continuous tube feeding, is a profoundly good therapy for a baby who's a big-time spitter. So it's a problem when it happens. It's surmountable, and that whole stomach and esophagus gets better over the first sort of 12 months of life, whether you have Alagille or not. So I think it happens, and then it happens in a huge number of kids with other things, and you just have to deal with it as an independent, process.
Mm. So, oh, yeah.
Our little guy has a G tube, and we do bolus feeds with him. And he, again, the waterfall is just a perfect analogy. But when it comes up, I mean, literally exactly the way it went in. I mean, it doesn't smell any different. It's not like a real vomit. Is that pretty normal?
Yeah, but he's year and a half.
He's 15 months, so
Yeah.
not quite a year and a half.
So, in younger kids, so when we vomit, it's like very forceful stomach contraction, and this muscle doesn't want to let go. So you get this ugly heave, and then things retch, and it's painful to watch, and it's painful to do. And in little kids, this muscle inappropriately opens up from time to time. And there are different stimuli that make it open up, and the stuff just like comes up, and they're like, oh yeah, I just soiled you, I soiled your rug, et cetera. On the other hand, if it happens with every feed at that age, he should probably get an upper GI. Can be done through the G-tube. And then you might want to think about, is bolus feeding the right way to feed him? Because the primary stimulus for that kind of reflux vomiting, and I think most of us say it is vomiting when it comes out the mouth in quantities, but it's effortless vomiting. It's just kind of like, like a humongous wet burp, is to take a lot of those calories into the nighttime and feed them continuously. And when you do that, they rarely vomit with that approach, and then you can keep smaller volume during the day, eat for joy. I mean, I think one of the biggest things about tube feeding, by whatever approach you use, is you're under tremendous pressure to get in enough calories, and the feeding events get really long, and they get hostile, and they get frustrated. And then the kids, they learn, I don't like to eat because mom is always, and dad's even worse. And then you go to, tube feeding, and it's like, okay, here's, some SpaghettiOs, and if you want them, great, and if not, it's okay, because we know you're growing even better because we're doing it at night. So I think that's the other side of things. But there are a lot of kids for whom bolus feeding, are you using regular concentration formula?
We use a Peptamen Junior 1.5, and then we mix it with a jar of baby food, and then a little bit of flaxseed oil and some Duocal.
Yeah. And so every kid is different. How much do you put in? 8 ounces?
No, we only do 5 ounces at a time, but even with, and that's where we got with, we were on continuous feeds, but it was severely restricting his mobility, and and he was having the same reflux issues.
You were
He-
doing them during the day or during night?
We were doing them for 22 hours a day.
Yeah.
So he was only taking a 2 hour. He would have like an hour break in the morning and like an hour break in
So
the
he
evening.
might be someone who has slow gastric emptying and might benefit from one of those kind of approaches. But then the other thing is you're putting in something that's highly particle dense, and you might find that, you know, a 1.5, if you vomit 50% of it, you're vomiting like a lot of super concentrated rocket fuel, and he might do better with 1.0. And you know, if you talk about breast milk is like 0.66, so you know a baby who's 15 months old who's breastfeeding is getting something that is way less than half as calorically dense as what you're doing, and so some stomachs can't take that easily. But the other thing to think about is you have a G tube that was placed that's like a low profile regular G tube.
Yeah, it's amazing.
So you could ask whether or not just taking that out and advancing that tube so that it's a GJ tube, and if you feed it down past the next muscle, there's usually very little vomiting, and that might be another approach to that.
Okay.
But then I think the other question is, proof of the pudding, is he growing?
He was growing really well up until a month ago when he got really mobile.
Mm.
And so we kind of switched everything up to see if maybe the reason he didn't grow as well, you know, in the last month was because now he's moving so much more and burning more calories versus.
Yeah.
So.
But if he reliably vomits 2 ounces at every feed, you should try to start by feeding him 2 fewer ounces and see if it quits.
We've started, instead of feeding him over 20 minutes, spreading it out over to like 45, and he does vomit significantly less.
Mm-hmm. So you might ask whether giving him Reglan or erythromycin before the feed would actually make that better. Ask your docs.
Okay. You said what? Redlan?
Reglan or erythromycin or bethanechol. These are 3 things that are used to sort of make the stomach move forward more and backwards less.
Okay.
The bethanechol, Bethanecol. The other thing you might do you ever vent him before you put the feed in?
Yeah, we vent, and he never really has.
You don't get much out?
He does. Yeah.
Yeah, I mean, there's some kids whose stomach is.
He has a lot of stomach wrenching, though. When you talked about the wrenching, you know when it's coming a lot of times because you'll hear that real hard wrench.
But you should ask for an upper GI and an X-ray test just to make sure that the next part of the bowel is like a smooth pipe that bends the right way.
Okay. Thank you.
Does anybody else have any other questions about that? Okay. Okay. So I think we dealt with the poop issue this morning. Is there anything additional that you'd like to share?
The only thing I would say, so I have a different opinion maybe, and since Phil is sitting here instead of someone else, you know, all those different colors, I don't think they matter one bit. Black matters. So if your kid poops black, stinky sweet, black, it's just like look at their color, check their pulse, call the doctor, you're going in. That's a sign that there was blood in the stomach. Green poop, brown poop, you know, white some days. White matters when you're getting diagnosed, but after that, I think it reflects a whole bunch of other things. And we're all at each of our centers now spending millions of dollars examining the bacteria in stool, and they really do matter for other things. But when you really obsess over baby's poop, it's all different stuff. And there are very few kids with Alagille syndrome who are constipated because they're leaking a lot of lubricant all the time. Black is bad. You would agree? Yeah.
Mm-hmm. All right.
That's yours.
I got one more.
Meds.
Wait, before this though, I
Okay.
got one more comment about poop. You know, there's an app that I carry around because in the old days, and probably David had this too, patients used to bring me presents when they came to clinic, so I could actually take a look at the color and consistency of a kid's poop. But now there's a Poop MD app. It's free. I can show it to you. It comes from Doug Mogul from Johns Hopkins. And the nice thing about that is when my patients bring me their specimens, it's readily digitalized, and they don't need to necessarily bring the actual product to clinic.
And do you put those pictures in the chart now?
I haven't, but I suspect you could. But parents could keep it in their Poop MD photo collection.
We put it in the chart, and sometimes we send a copy of it to the pediatrician. You're doing yucky meds.
Oh, yucky meds. And boy, I'm lucky.
Better lucky than yucky.
All right. So one question first, though, for Kristen. So with eating, before we get to meds, so with eating, is Emery picky? Do you have a problem getting her to eat? Is she?
Yeah. And it sounds like it's kind of a consensus for those with Alagille syndrome that carbohydrates are the chosen form of food. So pizza, bread, anything crunchy, cereal, oatmeal. Our whole family now learns how to play I'm going to eat this game at dinner, and the whole family plays every night, and we go around and we say something funny that we're eating that she thinks is funny to eat, like a starfish or Ariel or whatever. We make it fun. And to get her to eat protein and chicken and things that it's a texture thing for her, and yeah, it's harder to get her to eat things. It's always been kind of a struggle, but it's kind of an ebb and flow. I try not to freak out too much, especially if her growth is going well. But for her, it's carbs and just trying to add stuff to the carbs to make it better.
Right. What was the other thing I was going to ask you? So it is still kind of an issue for her.
Yeah.
Eating.
I mean, yeah, just now. She got excited about pizza right now, so I'm glad we had that. But yeah, certain things, she's pretty much a no for most of the stuff that we want to offer her, unless we're playing a game. Then she'll make it kind of choke it down a little bit.
Okay.
But she hasn't thrown up. She had reflux, but she hasn't had any issues with eating and throwing up as a toddler or anything like that. So that's good.
Okay. And then back on the tube, the NG tube, G tube, when a child is tube fed, and eventually I'm assuming you're going to want to make a transition to oral feeding. Are there issues associated with that? What are suggestions for dealing with that?
So I think it's critical that just because you're tube feeding a child doesn't mean that you should never offer them oral feeds, because some kids will forget how to eat. There's a real oral aversion. And it doesn't have to just be in Alagille's patients. I've seen it in kids getting liver transplants for biliary atresia, say, because they're getting tube fed to get the calories in. And it's a lot easier and a lot more convenient to do it that way. But you need to remember how to suck and swallow. And I would say from the get-go, any patient who's getting tube fed should continue to be challenged to take oral feeds, because it becomes critical. And you could do a very successful liver transplant and then have a patient who is stuck on tube feeds because they forgot how to suck and swallow.
Okay. So on to medications. They all end up taking some kind of medication, many of them lots of medications. And some of them are really awful. I tasted cholestyramine the first time I gave it to Elena, and she just, I fought with her every day to take that. And so, question, how do you, well, one, a couple of things. One, what might be some of the common medications that children with Alagille syndrome will at some point in their life probably be on? And then how do you get them to take those medicines, especially if they aren't tube fed?
Well, some of the common things would obviously be vitamin supplements, and vitamins can, consistency-wise, not be so tasty. They may be oily, in fact. Ursodeoxycholic acid now is probably a much better biliary choleritic. You know, it stimulates bile flow a lot better than trying to absorb bile acids with cholestyramine, which I personally didn't like to give my patients either because it's kind of like the consistency of sand. Seriously, and in fact, even adults trying to take cholestyramine was a big problem. And in the early days of cholestyramine, actually, if you didn't take it with enough liquid, and David, I'm sure, recalls this also, there were patients that presented with bowel obstruction because literally the cholestyramine was like sand, and it would just conglomerate in the intestine. And that's not a joke. I have found that most patients really don't take cholestyramine very well. Tubes can help because you can give a lot of meds via tubes that are disgustingly bad as far as trying to take orally. And if a patient already has oral aversion, I wouldn't be trying to get them to drink or eat by giving them disgustingly bad tasting medications. Now, in some regards, having medications not taste good is beneficial in some ways because nobody's going to then try to take an overdose of the medication as a result of it doesn't taste very good. So for certain meds, things that could be hepatotoxic, for example, it's probably not so bad that the medications don't taste great, because if everything tasted like, you know, bubble gum or cherry soda or something, somehow a patient might wind up taking an overdose of it. So in that regard, it may not be so bad. But in general, I would say, unfortunately, most of the medications are either bitter tasting or not pleasant tasting.
And a related question, I'm going to pull Jeff into the discussion here. So I don't think that there are medications related to, you know, cardiac problems or vascular problems, but if you have severe, you know, you may be facing with open heart surgery interventions to deal with some of the cardiac and vascular aspects of Alagille syndrome. So, and we did talk a little bit about those earlier today. So if you could talk some about what, you know, a newly diagnosed, you know, what some of the issues that you might be dealing with. We are going to dive deeper into it later, but and then also, if you are faced with open heart surgery, are there concerns about anesthesiology and what types of medications they would use?
So in answer to the first question, so most of the kids will undergo a couple of screening tests, the most common one being just an ultrasound. Once the diagnoses are made, then if they are readily repairable problems, we talked about coarctation, we talked about tetralogy, those kids in general, assuming that they need attention sooner rather than later, will go sooner rather than later. So many of the kids with tetralogy can go as early as 2 or 3 months to have that repair done. The anesthetic considerations are obviously in the purview of the anesthesia team, but they obviously take into consideration the liver function is probably the biggest piece of information that they use when they determine the types of medications. And in some of the kids with particularly profound liver disease, some of the medications can last a significantly longer amount of time than it would in somebody who doesn't have liver disease. So sometimes it takes a little bit longer to wake up. after the procedure as the body is busy trying to get rid of some of those medications. From the perspective of medications that they'll take from a heart perspective, you're right in that in general, most kids with the cardiac problems don't require a ton of medications. Almost all of them will require medications around the time of their surgeries, if they end up with surgeries. But in general, at least in the short term, most of them don't end up on medications long term. In some of the diseases like tetralogy of Fallot, they may end up back on medications later on. But in general, most of the diseases that we see associated with Alagille don't have long-term medical therapies. And all of our meds taste great.
And then a follow-up on medications related to heart, dental procedures, and are there concerns about pre-medicating before dental procedures?
Yeah, so there's two different answers to that question. Some of the kids with some forms of heart disease will need antibiotic treatment before they get dental work done. The reasons or the indications for getting the antibiotics changed. Everybody keeps talking about it just recently. It wasn't. It was about 7 years ago, give or take. So the number of reasons to get antibiotics has gotten much, much smaller. Some of the kids with Alagille will end up with that. For example, if even after their repair, they still have a little hole left, they may get told that they need antibiotics beforehand. And again, the same answer with the anesthesia around the time of dental work. Again, some of it depends, and I'll ask the GI guys to comment on this as well. Some of it depends on their liver work. But in general, the cardiac issues that we end up dealing with, assuming that they don't have significant heart failure, for example, we don't, I'll say it backwards, we don't not allow it to be done in an outpatient dental setting unless there are other particularly serious liver concerns.
Mm-hmm. And why would a child take antibiotics before a dental procedure without, they have Alagille syndrome?
Right. So when anybody has dental procedures done, some of the bacteria that are in your mouth end up in your bloodstream, and for the rest of us, we can clear that relatively easily. In kids with certain forms of congenital heart disease, they can still have areas where the blood kind of swirls around and kind of irritates the tissue that's around it. And if that happens, the bacteria can actually end up sticking to that area and end up having an infection in either the valve or the tissue of the heart. It's called endocarditis. And so the thing you'll hear the dentist ask is whether they need endocarditis prophylaxis. And so what the dose of antibiotics does is it circulates throughout the body so that when those few bacteria end up in the bloodstream after the procedure, they're taken care of rather than getting stuck to the parts of the heart or the valves.
Okay. And Kristen, as long as we're on the medication question, so what types of meds does Emery take, and what kind of experience is that?
Yeah. Well, actually, we're in the drug trial, through Lumina, and so she's just on that drug right now, currently, because she's doing so well on it. But she started with hydroxyzine and then to ursidile, I guess both of those, ursidile, then hydroxyzine, and then cholestyramine. And she happened to take that actually relatively well. They warned me and said that she would have to be tube fed to take it. And she, for some reason, I mixed it with some milk and shot it always right to the back corner of her throat, and she took it just fine. With all of them, I would give it to her usually in the bath. If anyone, I don't know, it sounds like a lot of you are tube fed, but if you don't and you're taking the Aqueducts with that hot orange stainer that stains your carpet, we had to replace our carpet. It was covered, but I learned to give the meds in the bathtub. It was just a great place in case they did spit it all back up. That was probably the only one that, because she had the reflux, the Aqueducts just kind of came up continually. And then we had rifampin, the really high dose, that's like a red stuff. And that actually did good work for her itch for a while. So we were on all of that. And she actually, for some reason, has done really well. I just got the good angle, getting it in, slipping it in, not letting her see it, kind of sneaking it in her cheek and not making it a thing. And eventually she just would drink it, and it was pretty amazing that she would just take it down. I know not all kids do that, but I've slowly weaned her actually off of all of them, and she's doing really well. Yeah, no, she doesn't, but Yeah, it's pretty amazing.
And then there was, as they get a little bit older, and we talked about, if you go from, liquid preparation medications to pills. And was it you, David, who said the thing about mini M&Ms to M&Ms to peanut M&Ms? Oh,
The mega.
mega M&Ms, okay. Any other suggestions? I've heard about Tic Tacs, to just kind of train them to take
we have
meds.
a psychologist who trains little kids how to swallow pills, and different people are different, but
Use the mic.
put it in a slice of a really ripe banana and just gum it and take it down, and I think you don't start with pills and you don't start with desperation, and I think we tell families a number of these things will be better if they're in pill form, and as somebody said yesterday, it's you can really train 2 and 3 year olds to swallow pills. I had one little guy with IBD who took 16 pills a day, and his older brother didn't want to learn, but he was 3, and he went home one weekend, and they came back Monday, and they said, you know what, he swallows all his pills, and he was like so proud that he was like he could do it, his brother didn't. Made some great rivalry, but when you have that many pills for other diseases, there are certain medications that can't be cracked open or made as a liquid. So that's not so much true for Alagille syndrome. But in other diseases, it's pill or nothing. And so, that's where you're really under the gun and you realize what little kids can really do. We also have little kids who put their own NG tube in at night and take it out in the morning, do it themselves. So not 1-year-olds, but
And then one last question with medications. So I know that some of them interact with others, and you have to be careful about timing on when they take certain things. Is there a better time of day to give medications, and what things might parents want to watch out for as far as interactions of medications and wanting to space them out?
so they've heard me.
That's not a simple question. And the reason why I'm saying that, it all depends on which meds they are. So that's very specific to each of the meds. Some meds you need to take with food, and other meds you need to take sort of on an empty stomach. Many meds probably makes no difference if you mix them together and take them all as a batch. But for some, you can't do that. And I think that's really needs to be individualized and needs to be discussed with your physician. Realizing that if a med is supposed to be taken on an empty stomach and you take it with food, that the med may be less effective at being absorbed. So that's the way I would answer your question. It's not, some of these kids are taking quite a number of meds, and it really makes a difference. And I think I heard Ruben mention something this morning about how there are certain meds that are, like your top 3 that you better make sure you get in. And I would agree with that wholeheartedly. If a child is sick and can't take, say, the 10 meds, well, you better make sure that there's certain ones that aren't missed.
All right, so our next topic here, which is a challenge when our kids are little, is sleeping. They're a lot of times they're very uncomfortable. They might be itching, which we'll talk about a little bit more later. They're just, their stomach might be hurting. They, maybe they're not breathing very well. All those kind of things. So, how do you get a good night's sleep? What do you do?
You don't. We honestly probably didn't sleep for 2 years. I mean, we're just kind of continually awake between the reflux and then the itching. And I guess it's such a it's not a black and white answer. I mean, every kid's going to have such a struggle in every different, and I think we were even talking a little bit about this, and that you're going to find the thing that they enjoy, the way that they're held when they're itchy, the kind of feel of pajamas. I mean, we went through pajamas after pajamas after pajamas to find the cool feel, cotton lotion after lotion, cool pack pillows. I mean, it was just a list, and that's really it was. It was just trial and error of finding the thing that they enjoyed or just helped them, and a lot of balancing between you and your partner or family members. It took a little bit of a mental breakdown for me before I called on family and friends because I've never had to ask for help before. And sometimes this isn't about getting sleep, it's about asking for help. And sometimes it's okay to say, friend down the street, can you come sit with my screaming baby for 3 hours? And it's hard to give up control a little bit, but that 3 hours made a huge, huge difference for my week and just having support. So for us, there wasn't ever an equation. I felt like we kind of went through seasons where it was really, really bad, and then it'd get a little bit better. So I guess I would say to do your best to ask for help, to keep finding different pajamas, lotions, just keep trying everything, and that know that this season will pass. You will sleep again, and try not to get really angry when your friends complain that their child has an ear infection or a cold and they lost one night of sleep. Just do your best and to take care of yourself during that time, because when you're not sleeping, everything else kind of falls apart as well. I guess then, like I said, just to know that there will be a day where you will, and they begin to manage it a little bit better. And a lot of it with the itching, as she gets older, we were so excited, she learned kind of how to wiggle herself in bed over us having to scratch her. She learned how to reach with her hand. And I know they say a lot about them getting better at that itching as they get older. And sometimes I feel like that's them managing the itch a little bit better, and they just start to learn how to get the itch, and she could fall asleep easier just even when she was itchy. It just took time, and that's probably not what you want to hear, but because it seems like it never ends, but it will. It will get better.
I think the things that you heard yesterday about not bathing too much, creams not lotions, something that is comfortable for them, heat that's not too dry, that's not too hot, and I'd be curious to see what Dr. Rosenthal says, but we never give the antihistamines round the clock. I would say never give the antihistamine, like Atarax, round the clock. We give a whoomp at night. And, the side effect of that is anti-itch and sleeping. And it actually, we think, works much better if you give one big dose at night than if you give it round the clock. And itching at 3 in the morning, given the same amount of itching, is way worse than itching at 3 in the afternoon. So, those medicines, when they're used around the clock, they seem to almost not work at all. But if you give one bigger dose in the evening, they sleep, you sleep, and maybe not for 9 hours, but it's a. You agree?
Yeah, I definitely agree. We don't try to slog people to be asleep all day long to try to control their itching, because I don't think it works very well. And number two, I think you just need to go higher and higher doses until basically nothing works. Somebody had mentioned rifampin, and I wished I understood better why in some patients it works great and in other patients it doesn't work at all, and why in some patients it works for a while, for a good while, and then it just stops working. There's a lot we don't know, but it definitely can help some patients that have bad itching, really relieve them. And the mechanism is really not well understood.
One other thing, air conditioning, if you have it, crank it up. They like it colder than you could ever think you would think would be cold enough. We're freezing, but she would sleep a lot better when it was really cold. And like you said, the bath, one day it just clicked. We put her in the bath and she just screamed the feel of bath water. So it was very mild, cool almost water, not a normal warm bath for kids kind of bath. No bubbles, no soap, just mild cold water and an organic. We got just like an organic shampoo and didn't even really wash her skin very often. They don't really need it that often unless they've been vomiting all over themselves. Very much, and like he said, any kind of cream or anything.
Yeah, ointment, not cream. And kids don't need a bath. So take them in the shower with you. You know, it's kind of like a fun bonding thing. And it can be 2 or 3 minutes. And probably the only thing that really needs to be washed is their hair occasionally. And the rest of the stuff's, you know, they don't stink. They're little kids. And but the soaps that we use and lotions are like really good for a little bit, but then they really dry out the skin. So, you know, the dermatologists really don't, the cosmetologists love those, but the dermatologists really want you to slather the kids with something, or at least the hands and the feet, with something which is really ointment, not cream, not lotion. So it seems a little icky, sticky, and you know, you're going to have to wash the sheets and so on, but that before bedtime, I think, is another really good thing. And I think you know that hands and feet in the cholestatic kids with Alagille syndrome, the ones who are really are liver, the skin gets very thick, a little sweaty, you know, I mean, there really are, and it's a combination of things from the inside, plus that's always, you know, being itched and lichenified and thickened, and so you really want to try to smooth that out and treat that directly. And when their cholestasis gets better, those changes mostly go away, or when they get transplanted, those changes mostly go away. But it takes like a year or two for those to go back to normal.
So as long as we're on the subject of itching, one of our favorite topics. So itching, you guys do, yeah, okay. Is there anything new on the itching front? Or how do you, you know, there are medications, there are different things that, you know, like we've been talking about. You know, any
Yeah, we did. I
new
mean, we did a little bit of
developments,
this
new
this morning. I don't know if people want to, you know, do a little bit more, but other than inhibiting the uptake of, you know, bile salts, which is also a little bit kind of done in a different way by cholestyramine, done a little bit in a different way by the ileal exclusion therapy or by the external diversion therapy. You know, really the next wave of this is they've started to understand which nerve fibers actually carry this sensation, and certainly you feel itch kind of in your brain more than in your skin. So there'll be new medications for itch. We said this morning there's the medication that treats the itch, and then there's the medication that treats the chemical that makes the itch, and those are different strategies, and most people do best by, I mean, I think a lot of our people who have their itching under control are on 5 different strategies to decrease their itch, and then finally it gets good. It's like that last one thing you add in, and it, you know, I agree with Phil that half the time rifampin is magical and half the time it's like a bust. But same sort of thing with like naltrexone. I mean, that might be the thing that you finally add at the end, and all of a sudden life is really good enough. But you need the urso, you need the atarax, you know, you need these other things as well. You know, and it's the combination. Maybe each one by its own pathway takes out 20%, and then you finally get to the point where life is good enough.
Go ahead.
Well, I just wanted to mention my daughter is in an itch drug trial, who was originally through Lumina Pharmaceuticals, and it's now Shire Pharmaceuticals. So we're out of Seattle, and about 6 days after she started that trial, she's become completely itch-free. So that's when we started sleeping. But there are trials going on to, you know, to get, you can look into and start seeing if that's something that your family might be interested in. And it's been really great for us. We travel, but it's been worth it for now. But it is a trial, so it's not a guarantee or something that, you're guaranteed to have for long term. But it's bought us some really great time because she's completely normal in our world right now.
Mhm. Yeah, and the drug that Kristen is talking about, it's what's called a bile acid transport inhibitor. So what it does is kind of mimics a diversion, where it will, rather than the bile being reabsorbed and recirculated into the body, this drug makes the portion of the small intestine that would normally reabsorb the bile not reabsorb it. I'm hoping I'm doing this correctly. And so it bypasses that portion of the intestine and it gets excreted in the poop. So it's in trials, and kind of results are coming back slowly. So crossing fingers. It's the first time we've ever had a drug that dealt with anything with Alagille syndrome. So we're optimistic about it. Let's see. I think. So there's kind of the hearing vision development questions. We talked about those some this morning, and that there are some some vision can be impaired, hearing can be affected by Alagille syndrome. Are any of you dealing with any kind of vision or hearing issues? Okay. All right. Well, it may be something that comes up later as well. Highly variable. This disease is like a roll of the dice. Never really kind of know what's going to happen. And I'm just going to roll through the rest of this. Having a health plan for your child is helpful. We are working on a resource that we're calling the ALGS Care Navigator that hopefully we're going to roll out later this year. It'll be a notebook where you can track lab results. You can put information about the specialist that your child sees, contact information, what medications they're on. And just kind of what a health plan is for them. That then when you get to go like on a date night or a vacation or something, you can give this to the person who is going to be watching your child, and they'll know everything about them, and you'll be able to rest easy and kind of get a break for yourself. So we are working on that coming up. And then just some other helpful resources. So we had the ALGS Care, there's the Care Navigator. When your child gets a little bit older and you're wanting them to understand better what Alagille syndrome is, how it affects them, we do have a coloring book for kids, and they've been using that in Camp Alagille today with the kids to start them on that path of understanding it better. We also do have a classroom guide. So when your kids get into preschool and on up, looking at some of the challenges they face in the classroom, and it's a tool for both you as parents as well as for teachers and staff to better understand Alagille syndrome and what they might be needing to look out for. And we are also going to be adding a family portal to the website that will have some resources on it as well. So I think that's it on my part, and now it's time for you guys. So what didn't we talk about that you want to know about? There you go. Patty, can you?
I have two questions. The first is all those resources are posted online that you missed it, or do you have to?
Not quite yet.
Okay.
We're getting there.
Okay, awesome.
we just revamped our website, so we're gonna be working on the family portal, and those will all be on there.
And then the second question is with the sleep. Do you ever try to use melatonin to kind of like decrease to help the child go to sleep and have less? Does that affect? Because itching probably keeps awake. So does melatonin help? Because in small doses, I've heard it's okay for kids. I don't know.
I just want to put my opinion in on just some of that. We got a lot of thoughts on her being able to go to sleep, and the way I like to describe it as someone who maybe doesn't witness a child try it and go to sleep at night. It's kind of like you've lit them on fire, and you're going to give them something very little to try and ease them to go to sleep. It's not so much about the fact that they can't fall asleep. It's more about they're in such a suffering pain that they can't go to sleep, if that makes any sense. So they don't, and I'm sure there might be children that actually maybe have sleep disorders, or, but when it's related to the itch specifically, she's a great sleeper outside of the itch. She sleeps fabulous now that she's not itching 12 hours, she'll sleep. It's not that she couldn't go to sleep, she was basically on fire. And so those kinds of things didn't do anything. She just needed to be relieved of pain. But that's just my opinion on what that looked like, or a way to describe to others when was handed essential oils and all kinds of things when they said she wasn't sleeping, or when I would, pass that information on. It was just, they were trying to help, but that wasn't the underlying issue for us. But
Yeah. Not dangerous, not usually effective. We don't object if people want to try it.
Well, I would agree. My comment to you is that lots of people mean really well, but in general, that doesn't really get to the underlying mechanism of what's going on. Melatonin in a reasonable dose is going to probably hurt anybody with Alagille's, but I have not heard of patients taking melatonin and having their sleep, 12 hours a night kind of thing.
Thank you.
All right, so before anybody else gets sleepy, we should have a coffee break. Are we doing coffee break next? Is there a coffee break? Maybe I'm advertising something that doesn't exist.
Yes,
False advertising.
I got a question for David then. Does caffeine have any value for Alagille patients?
So I don't think so, but I don't know. We used to use, when Dr. Rosenthal was young, we used to use caffeine as a measure of liver function, and could even suck it out of the saliva in the cheek, and it was a very hot test. I always sort of thought it was better to drink it than to, so I don't know. Do you have feelings on caffeine? I do feel, I would say during the daytime, run your kids. If you want to have them sleep at night, don't let them sleep during the day. So you get into this vicious cycle, and there are liver kids, and it is one sign of liver dysfunction that I think transplant people, I always get the point here because there's always been a transplant doc over here, that when they get somewhat advanced disease, they have day-night reversal, and so they are up at night because of liver things. It's usually a little bit different than Alagille, but there are families that say, my kid sleeps great during the day, and then they drive me mashugana all night long because they're up all night and they want me up too, and I can't do it. So there are some people where it's the timing is wrong, and it's kind of like when you have an infant, just in general, there's a time to cut the nap so that they'll sleep, and there's a time to no longer give them a bottle at 3 a.m. because they'll keep waking up for the bottle. So I think good exercise, activity, and awake during the day, try to get rid of the big naps, and then you are more likely to get some better sleep at night. Same's probably true for all of us. Are we getting snoozy? We're gonna have coffee? Yeah. Sorry.
Yeah. To answer David's question, yes, there is a break. It's at 3:15, so we have a little bit of time before then. And Kristen, go ahead.
Oh, I was just thinking about the sleep during the day. I don't know about you guys. Do your kids take that nap a little bit better than at night? So us parents really like that time to let well, I guess I want to say is that for M, that was the time I saw her finally sleep a little soundly. For some reason during the day, I don't know why that is, because they're still falling asleep. I don't really know the difference, but when you got really little ones, is it still okay to give them that hour nap? You know, that good, not a, well, a year, year and a half,
Are they
two.
sleeping at night or not?
Well, she slept without itching. So it wasn't necessarily that she wasn't tired. She was exhausted. She just couldn't sleep. It was like the witching hour, right about 8 or 9 o'clock. And you guys know. And it was usually around 3 when she would sleep. The early morning hours, I don't know what it was. All of a sudden, the itch calmed and she kind of would go into a sleep. I don't know if you guys find that at night, that the first part of the night is harder, or? Mm-hmm.
Up until probably, I don't know, 2 or 3.
Yeah.
And that'll be kind of his last wake, and then he'll sleep. And then,
Into the morning.
unfortunately, I have to wake him up at 6:30 so that we can go to. And it's like he's finally asleep.
Yeah.
But yeah, I mean, it's that evening until about 3 a.m.
Mhm.
where he wakes up and he's just hurting,
Yeah.
and then he sleeps.
Yeah.
So I kind of
So-
think, like, why even bother going to bed until 3 a.m.?
Yeah. And you know what? And just mentally, I feel like setting yourself up to go, I'm going to be prepared to stay up and not think, I'm going to go to bed at 9 and watch my favorite show and lay in bed like normal people do. I'm just going to, we're up. We're on. Yeah. Does anybody else have any other questions about sleeping or? Yeah.
2 other questions that kind of intrigue me. One of which is, are all of the meds that are kind of typical meds, like rifampin, Ursodil, those, do they all come in like a pill form? Or some
Well-
of them only liquid?
So like Questran, I think you can't get the pill form anymore for, a number of them only come in a pill, and you have to get them made into a liquid, which
Right.
is actually a huge issue at the level of some pharmacies and some insurance plans, because the compounding pharmacies sometimes charge an extraordinary amount, and then your plan will say no compounded meds, and then you're kind of stuck in the middle. So what comes only as a,
Does calcitriol come in anything but liquid?
yeah, I think calcitriol comes in a pill.
Okay.
I think you might get that compounded, actually. You don't get that. Here, he's got his med app. He
I
does.
was like, rifampin and Ursodil I know are compounded, and we are fortunate that we have a pharmacy where the pharmacist has a liver baby, and so she compounds for liver patients, which is very nice and very helpful. But he did just recently started taking the chewable Aquadex, which is way better, because he can just pop that in and eat it rather than the liquid going everywhere. So I was just curious how far away he just turned 2 last week, but how far away we might be from, because it's easier to take, 9 pills than 9 liquids, and it's easier to travel with pills, and it's easier to be out in public with pills than trying to, refrigerate things.
So calcitriol
Mhm.
has 2 capsules and the commercial liquid.
Okay.
So that's one where the liquid's probably paid for. If a pharmacy makes a liquid med, it usually costs a lot more, and the half-life, the shelf time that they give you is, depending on what it is, maybe only a week, and you have to go back every week, and I don't think it's ever more than once a month,
Ours are the rifampin is once a month.
Yeah.
It's like actually like 28 days, I think.
Yeah. But some of the meds come as a commercial liquid. So, the calcitriol is like very important for like kidney failure patients. And kidney disease in kids falls under adult Medicare kidney guidelines. I mean, from all kinds of different things, that's a big advantage. So that med, it's not surprising that it comes as a commercial med. But if you want to try to get, vitamin K, or, for us, for URSA, which is so, everybody's on URSA almost. I mean, there are a lot of times where we just tell the parents, this is the amount of the pill that you're going to take, and it comes in 2 different pill sizes, and just you do it right at the time, point of time. Naltrexone, which is really sort of made for adult opioid users. It's an inhibitor, and it's a great anti-itch medicine. It comes in a pill that is like this big. It is like 10 to 25 times more per pill than your kid needs a day. So we teach our parents how to be kind of like, dope cutters, and, they get a razor blade and a mirror and chop it up. And you have the assurity with that medicine that if you give 30 or 50% too much of that medicine, because you don't crack it right in half with your pill cutter, makes no difference whatsoever, because you really can't like OD on that, sort of medicine. But the preps and the charge on the preps and whether they're covered or not, and as things have changed, plans have tried very hard to shift the costs to, their clients, meaning you. And so sometimes you really have to figure out, if you're going to pay 30 times more out of pocket for liquid urso, you may as well figure out a way that you can adequately solubilize it and deliver it yourself. And it is kind of here it is, you get half the pill, crunch it up, syringe, boom, we're done, and we just save $10.
My second question is about the G tube. Our son had an NG tube from the time he was about 8 months old for a year. So he got rid of it about, 4 months ago. And at this point, he's growing. I mean, he's following his own growth curve. He's actually on the chart and has been steadily for a while. But I still...
On the regular chart.
On the regular chart.
So that's excellent.
But, I mean, he's like low on it, but he's on it. And our other two kids are tiny as well, and they don't have ALGS. So... But my question is, at what point, I mean, it's what you talked about, meal times are stressful. I mean, he drinks Pediasure. He will always drink it. We don't have that issue, so we know he's getting the calories from the Pediasure. But meal times are stressful. I mean, he eats at daycare, I think, because all the kids are eating, and that's what you do. And they play a game where everyone has to feed Tanner. And so he eats because everyone's feeding him. But at what point, I mean, it is stressful. I mean, every meal we're kind of going, did he eat anything? So I guess my question is, would a G-tube still be beneficial if he's drinking Pediasure and is following his own curve?
So I think most of us would say no to that. It would not be beneficial. You want to keep some solids going in. You want to figure out the 5 solids that he likes. And, if it's, nuggets and, little, hot dogs in a bun or something that, is tasty, fried, and fatty, it's okay. Yeah. I think, though, you do get one clue that the feeding teams always use, and this is the can't do, won't do dichotomy. So when the kids go to grandma's or when they go to daycare or school, and if they eat just because, then they can eat, and this is one of their control things. And, when you have a 2-year-old, they take control over certain things, and most parents, particularly by the time you have 3 or 4 kids, you're like, okay, you'll be 3 sometime, like next year, We're much more concerned if a child develops texture preferences or a purely liquid diet and won't do anything anywhere under any circumstance. So if you want him to eat at home, invite all the kids from daycare, and then you get out of the kitchen, give him the dip, and turn on the video camera and see what happens. Yeah, but I'd say the dipping thing. I mean, I think we said this yesterday. I'm starting to get lost in all these sessions, but kids like spicy, tart, vinegary. I think this is what they taste, and it tastes good to them. So I mean, I'm amazed when I hear that a 4-year-old puts sriracha on their hot dog, and I'm like, wow. But okay, and it's not a little bit, it's like ketchup, But it is what many of the kids find makes their food good to them, and I say use it, you know.
I was also going to say in the presentation, the food, you probably know this with your other kids. I will give Emery even just like a yogurt packet in the squeeze. The kids love that. She's something about putting, like having her mouth, and she would like it, and then all of a sudden she didn't. I squeezed it into a bowl, gave her a fun, aerial spoon, and she ate it. Changing the way I served the food. Maybe not even sitting at the table perfectly, just how we are expecting our other children to eat. I kind of laxed a little bit. If you want to eat on the floor by the table, I don't care where you eat. Eat the food, So just mixing it up, making it a little more fun seems to help a little bit. And you may already know that, but that seems. Mm-hmm. 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 Yeah. And taking into the consideration that they're a toddler, and if your other children had behaved like this, you wouldn't be thinking so much about it. But we do now. We just think about it a lot, and giving yourself a little bit of a break, like you said, that he's on the curve, and just thinking a little bit outside the box of the other kids and feeling okay. I know I struggle when I'm doing things a little differently for her, letting her have things that the other ones wouldn't, and just going. But that's the boys might say, well, this isn't fair, and I say, well, you guys are all very different. You're all going to be living different lives. You might hear this from your other kids, and that you also don't have Alagille Syndrome, buddy, and that's not fair for Emery, right? That she lives this, and that you don't. So, just kind of explain it in that way, mixing it up a little bit for her, and letting go of the guilt, because I'm a type A and everything must be, and you sit at the table, and and you have to let it go. You just do a little bit.
I think I'm done.
So I had a question for all you guys out there. We've talked a lot about liver-related stuff, not much about heart and vascular issues. Can we just kind of go around and just, if you can tell us, are there things do you have pulmonary stenosis that you're dealing with, VSD, anything like that?
Yeah.
We're primarily dealing with liver. For us, we had slight pulmonary stenosis last, was it April? I think this past April, really nothing, no traces left when we met with the cardiologist. So very little trace, nothing to be concerned about. And at this point for that, and I think that's all. Pretty much liver. So this has been very, very good for us. So.
Actually, we started our journey with the heart because we knew something was wrong as soon as he was born. We just didn't know exactly what it was. So our pediatrician was having us come in like every 2 days for weight checks. And at 2 weeks, she heard what turned out a murmur. Then we were referred to cardiology, and they found an ASD and a VSD. And he was on medication for that up until he was right before he turned a year old. And one has closed significantly, and the other one is closed a little bit, enough that they felt comfortable. The cardiologist felt comfortable taking him off of the 2 heart meds he was on. So now we just follow up with them every 3 months. But the liver is pretty much our major issue, but the heart brought us there.
Any pulmonary stenosis?
There was some stuff that I wrote down that I'm going to have them check, because we actually go July 5th, and our cardiologist is not my favorite specialist. So there's some stuff. I don't know, like he wasn't on the Alagille's train with us while we got our clinical diagnosis at 7 weeks, but we didn't. And then we got a false negative on our first genetic testing. And it wasn't until he was 8 months old that we got the genetic confirmation. And so he was an Alagille's doubter the whole time and kept telling us, it's not it, that's not it, it's something else. I don't know what it is, but it's something else. It's not Alagille's. I'm telling you, it's not that, blah, blah, blah. And so kind of, I'm like, here, Did you read that? You got that paper that said that's what it was? Like, that's what we've been telling you for this long, and like you read that clearly. And so there's some stuff that I have that I want to take back because I don't know, because I didn't know what questions to ask. So this was helpful to kind of know where to start out with, to check and see if there is any of that pulmonary stenosis and other stuff.
Find another one for a dime a dozen.
Well, and that's kind of. He's the only. He's. I didn't say that on the mic, by the way. Well, and that's kind of the way I felt until we kind of came over the hurdle. But depending on what the next echo comes out, I very well may be asking. I don't know. I just didn't get a good vibe from him from our very first meeting. And he didn't even do anything wrong at that point. It was just like, I just, you just don't get that mom bond. Like our GI and our nutritionist, I just think they're like the best people in the whole entire world. So
I think it's always fine to change doctors. And I think there's a couple of things, and we've sort of said them a little bit. So you could ask your hepatologist, okay, look, I'm not really clicking with Dr. X, so just help me get another person, because I don't want to leave Michigan and go to your competitor, because that's really going to embarrass you. So just find me somebody else in the division. I mean, in our division, which has, like almost 50 physicians now, we just have a policy. If you don't like this one, we'll find you another one in the group, because it would break our heart if you decided you had to leave us to go, somewhere else. So that's number one. And number two, I think whatever specialist you go to see, there's a chance, if you've read 4 websites and 4 papers, that you might have a broader view of Alagille syndrome than some of these specialists. I mean, your liver doctor, some of your liver doctors have seen 5 Alagille cases, but some of your, maybe. Is that what you said, maybe? Yeah, maybe. But some of your cardiologists have seen none. So you can help them, the ophthalmologist, the nephrologist. I mean, whenever we send somebody to a nephrologist now, we tell people, take this paper with you, or send them the paper with your records and let them look at it. I mean, really honestly, they want to do well by you. They want to look good. They don't want to, I think physicians don't love being out Dr. Googled, and on rare diseases, unless you do this a lot, we said, there's 24 eye findings, there's all kinds of different kidney disease, but there are papers that detail 200 cardiac patients and the whole spectrum of disease and, all those different things. And, so sometimes I think, there's that old movie line from some movie from like 1942 that, Bogart and, she kisses him and he says, what'd you think? And she goes, well, it'd be better if you helped, sort of thing. And I think that's true for medical care. Cindy was talking a little bit. A lot of people have gone to 5 different centers. They searched around, maybe they didn't get the right diagnosis at first, or they couldn't find the right people or whatever. You can't go into center number 6 with no records and expect them to do anything useful. It's like, we are really annoying. We will not do a second opinion until the records have come in and we looked at them and said they're the records we want. Because there's no sense flying in from Michigan and spent 3 people and spending $2,000 on the planes and the hotel and everything else, none of which is going to be reimbursed, from insurance. And then we're looking, and it's just like, all this stuff has been done, and there's 1,000 pages of records, and they're somewhere else. So I think carrying those records, helping people to know, but you got to find the person that you like, and if you don't like this person, it might even be time to switch before, or you could, give them one more chance. But you should feel guilty about that. It's like if it's a car dealer, you don't like this car dealer, you don't buy your next car from them. Just go down the street.
Wait, so we went from $1 a dozen to a car dealer?
I was.
I did not make that connection.
You did. That's exactly what you did.
Well, I would say cardiology's car dealers, GI, we're used car dealers.
I was just gonna say we were in the exact same boat as you. We loved our GI, loved our nephrologist, and cardiology was just rough. It was just did not agree with where they're going with it. And I just say from a mom's perspective is you can't care what the doctors think of you and what if you're gonna hurt their feelings. You got to speak up and be okay to say I don't want, and we did. We finally said no, and we were able to get a second opinion. We personally contacted a cardiologist at CHOP. She was fabulous. I emailed her, got the records to her. She reviewed them. She called me personally on the phone. She walked me through all of it, was very honest with me, but didn't give me a concrete. She said, eventually we all get to decide what we want to do. And put that in my hands. But I was able to go back with a little bit more information. And I said, I want to see somebody new. And I actually connected with another mom that happens to be going to the same hospital that we are, and connected with a doctor that does see an ALGS patient that has had experience and that understands that I will be contacting somebody else. You will be working with somebody else that deals with more ALGS patients, and that's okay. And if they're not willing to, it's okay to say you don't want to work with them. Because now I feel safe to talk to him, and he will talk with me, and he knows that if anything needs to go down, we have pulmonary stenosis going on, that we will be traveling, and that's how that's going to work, and he's okay with that. So it might take some time to find someone, but if you're not feeling it now, you're not going to feel it later.
Thank you.
Yeah, two other pieces to that. Echo may not be the only test that you need to make the diagnosis. Echo's great at looking things sort of in general around the heart. A lot of the pulmonic stenosis is out much further than the heart, so you can't actually see it by echo. So oftentimes we'll do other versions of testing to take a look at that. And the second opinion, the second thing is any doctor who doesn't want a second opinion or to be co-managed by what we'll call experts is probably not the best team player, right? So it doesn't matter what the disease is. There's, in general, specialists, especially in the pediatric world, even subspecialists. And so it's not at all unreasonable to keep in contact with a center like CHOP or UC or Stanford or whatever it happens to be and get a ton of your care locally anyway, right? So the team there, just make sure that you're dotting the I's, crossing the T's, getting the testing you need, getting the follow-up you need. But it doesn't mean that the local doc can't be part of that. It shouldn't be an either or all the time.
Yeah, no, in fact, a lot of times you have to have boots on the ground. So, we're not willing to take care of complicated sick kids from 6 states away unless they can find a person who will also be the urgent care local. There are just certain things that you can't just kind of like drive from Florida to Philadelphia when you have a problem at 2 in the morning. So, that communication, I think, it goes both ways. I mean, the specialist or the sub whatever also has to be willing and able to communicate, collaborate, direct, be receptive, and if, the call goes around the primary person, then the specialist also has to, incorporate the local person into the discussion. But I think in general, everybody wants things to do well and go well. And I think for most of us, when somebody asks us something that we really don't have a great opinion about, I think our strength is we just know who to ask. Particularly in the big centers, there's always someone to ask who has like an interest in this weird little thing, and that's very helpful, and that's what you want, because you have rare things, and then you have the rare thing of the rare thing,
I was just gonna add on to, as a parent, going into those rooms and feeling a little intimidated by those white coats staring at you. Really equipping yourself this weekend will really help you. You'll leave feeling so confident walking in that room. That especially happened for me. But preparing a packet, and maybe you already have a booklet, whether you start to use the care, but going in with these findings and carrying them to everywhere, the dentist, all the specialties, because it affects all of it. And knowing, like my pediatrician said, I've never seen an ALGS patient, and you will be teaching me, Kristen, about this. And that weighted a little heavy on me because I thought, no, I come to you for answers. And just kind of accepting that and just going, this is my role, and being prepared and feeling confident to speak up and say, I want this done. I want being proactive and not feeling guilty about it when they kind of question you or wonder, well, we don't really need to do that right now. And it's okay to be a little persistent. And it sounds like everyone's kind of like that. But for me, it was a struggle. I was very non-confrontational, and I'm a rule follower, and I just did what they said. And it took this conference for me to be able to stand up and say, no, I don't want to do that way. I'd like to do this. So I just want to encourage anyone that maybe feels that way, you know, walking into a doctor's office can be a little intimidating.
Kristen, can I ask you a question? And maybe I'm out to lunch, maybe Phil's going to hit me. Have you really ever seen a doctor in a white coat in pediatrics?
Yeah. My cardiologist are all wearing white coats. Well, I'm at Dornbecker. It's such a mic hog. No, we're at Dornbecker OHSU, so they are a teaching hospital, and they have a team of people following me around in a white coat. Do you guys see white coats? No? Okay.
I have to say I have one white coat. It was issued to me in 1983. And we did a photo shoot recently, and one of the photo shooty people said, get your white coat. And I said, oh my God, I know which closet it's in. It has my name on it, one. And I've never, since I've been chief, given anybody a white coat, ever. And I went and looked at the size of it, and I was just so much thinner then. And, but I think in our 1,000 physicians in the academic center, I'm not sure I've ever seen a white coat. I think some of the surgeons have them when they put them over their dirty scrubs. Yeah, I bet it over the white coat over the scrubs. Yeah, it's an elegant blue and white look. Yeah. So I think the medical students, they have a white, so and maybe cardiology, because they're a clean specialty. Okay, so if they don't wash that coat for 2 weeks, it's still clean looking. I can assure you in GI, we have an outer wrap that 8 to 15 times a day we take off and dump in a bin. You know?
It's an OHSU thing. It's an OHSU thing.
But the medical students now, there is something called a white coat ceremony, and it didn't exist when we were young. Can you remember when we were young?
I can still remember.
Yeah, I look it up in my journal.
I work at a hospital too.
Yeah.
I'm a lab assistant.
Yeah.
All the doctors walk around in white coats.
Lovely. Wow.
It's an Oregon thing, apparently.
Okay. All right. Well, in any case, I'm glad, and I want a picture.
I will send you.
All right.
All right, so any last burning question? We have time for like one more question, and then I'm going to give out, the coffee's waiting for you out there. Then I have feedback forms that I have to give out to everybody. So one more question? Anybody? All right.
How do I look?
Yeah. He needs a break. He's losing it.
All right, let's give a hand to our panelists up here. And let's see, break from 3:15 to 3:30, and then we are in a second set of deep dive sessions. Yes.